Hello, my name is Dr. Rebecca Keith, and today I'm going to talk about pulmonary function testing and how we can use them to help our patients and to better understand their lung diseases. I see patients in both my interstitial lung disease clinic and my autoimmune lung disease clinic. Every day I use pulmonary physiology to better help me understand what's going on with my patient. They're an invaluable tool to help me take better care of my patient and not only identify what's going on, but also to know what's going on with them over time. I hope that this presentation helps you do the same. Let's get started. This presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals Incorporated. The company has provided financial support for this program. Presentation content has been reviewed for consistency with FDA guidelines. Today, our learning objectives are to better understand the core pulmonary function tests. This includes spirometry, lung volumes, and DLCO. We are going to try to identify restrictive, obstructive, and mixed obstructive-restrictive patterns on pulmonary function testing. Finally, we're going to utilize this approach to the interpretation of pulmonary function testings in several illustrative cases. Pulmonary function tests are non-invasive tests that can measure specific pulmonary parameters, including lung volumes, capacities, airflow, and diffusion. Let's start with spirometry. Spirometry generally measures airflow. It can look at pulmonary mechanics and flow volume loops. It's most effective at identifying obstructive lung defects, and it's less precise at identifying restrictive lung defects. Pulmonary function testing, including measurement of lung volumes, is much more accurate when we want to consider restrictive lung defects. When we look at spirometry, we're not able to measure directly all lung volumes. In fact, we're not able to directly measure residual volume. So in that case, we use body plethysmography, nitrogen washout, or helium dilution to identify total lung capacity. And from that, we can back calculate unmeasurable lung volumes, such as residual lung volumes. Let's finally look at DLCO. This measures the diffusion capacity of carbon monoxide to assess how well oxygen and carbon dioxide diffuse across the alveolar capillary membrane. Low DLCO can suggest restriction, possible obstruction, or pulmonary vascular disease. Pulmonary physiology is made up of lung volumes and lung capacities. Lung volumes often measure the amount of air with one inspiration or one expiration, while lung capacities often measure several lung volumes, either two or more at a time. For example, total lung capacity is made up of the inspiratory reserve volume, the tidal volume, the expiratory reserve volume, and the residual volume. We can look at that a different way. This will be important as we move forward. The total lung capacity is generally made up of the forced vital capacity, or here the vital capacity, plus the residual volume. Let's look at spirometry. Spirometry is fundamental in assessing pulmonary function and mostly looks at airflow. Spirometry measures the maximum volume of air one can inspire or expire with maximum effort. The most relevant measurements are FVC, FEV1, and the FEV1 to FVC ratio. Spirometry is an important step in trying to determine if a patient has an obstructive or suggestion of a restrictive defect. We can look at FVC, FEV1, and the FEV1 to FVC ratio to help us determine this. In an obstructive defect, we may see a normal to reduced FVC, but a bigger reduction in the FEV1 because patients with obstructive lung disease have trouble getting all of their air out quickly. So in obstructive lung disease, we may see that the FEV1 is reduced more than the FVC, making the FEV1 to FVC ratio reduced. In restrictive lung disease, patients have a reduced ability to move air in and out of the lungs. This can be due to many different things. We can see that parenchymal lung disease, such as interstitial lung disease, can reduce the size of the lungs, thereby decreasing the amount of air that patients move in and out. We can often see a pattern suggestive of restriction in other things as well, including obesity, chest wall disease, or pleural lung disease. All of these disorders can shrink the size of the lung and the amount of air that can be moved in and out of the lung in total. Here is depicted a flow volume loop. You can see here that the upper portion is expiration, while the lower portion depicts inspiration. The FVC is the maximum volume of air that an individual can exhale for the total duration of the test, with a maximal forced effort after maximal inspiration. So essentially, we have patients take a deep breath in and then forcefully blow all of their air out until they're unable to blow any more air out of their lungs. The FEV1 is the maximum volume of air that can be exhaled from the lungs as forcibly as possible in the first second, and this is measured in liters. In general, people are able to get at least 80% of their lung volume out in the first second. Then we can look at the ratio of the FEV1 to FVC, as a portion of vital capacity one can expire in the first second relative to all of the air that they can get out in total. And this can help us identify things like obstructive lung defects, in which people have trouble getting air out quickly. And we often see that the FEV1 is reduced more than the FVC. The pointy part of the flow volume curve depicted here is the peak expiratory flow. Evaluating the measurements we obtain from a patient with spirometry is only meaningful when we compare them to normative values. Well, how do we get normative values? We have reference equations that take into consider factors such as age, sex, race, or ethnicity to predict the average lung function and expected values. There are two main reference values that we use. The Global Lung Function Initiative, or GLI, network ERS collaboration, includes individuals aged 3 to 95 from 26 different countries. It is recommended by the ATS and ERS to use this as our preferred reference value for pulmonary physiology. It provides reference values for whites, Northeast Asians, African Americans, and Southeast Asians. The other reference value that is commonly used is the National Health and Nutrition Examination Survey, or NHANES-3. This includes individuals aged 8 to 80 years. There are separate recommendations available for children under 8. Extrapolating to patients older than the age of 80 is not generally recommended. This set of reference values provides reference values for whites, African Americans, Mexican Americans, and the United States. We often use the lower limit of normal, or LLN, to delineate between healthy and diseased states. We'll look at this more as we go through cases and examples later in the talk. The lower limit of normal is defined as the 5th percentile of the mean predicted value. It takes into account the patient's sex, age, and height when we calculate the lower limit of normal. The Global Initiative for Chronic Obstructive Lung Disease, or GOLD criteria, recommend using a fixed ratio and is commonly used 80% of the predicted value for FVC or 70% of the FEV1 to FVC ratio. These values are estimated based on middle-aged adults, resulting in a risk of underestimating the degree of obstructive lung defect in young people while overestimating the amount of obstructive lung disease in elderly individuals. Let's take a moment to look at the flow volume loops that we commonly see in obstructive and restrictive lung diseases. So in obstructive lung defect, such as asthma or COPD, we often see a normal or reduced FEV1 and FVC, but a reduced FEV1 to FVC ratio. The flow volume loop often shows coving or a scooped appearance. Some people say that these flow volume loops appear short and compressed compared to other flow volume loops, such as in restrictive lung disease or in normal patients. Here we can see in this example, the FVC is 66% of what we'd expect based on a normative value, and the FEV1 is 38% of what we'd expect based on a normative value. Here, the FEV1 to FVC ratio is 0.46, and this is illustrative of an obstructive lung defect. Next, let's look at the flow volume loop that we'd expect to see for a restrictive lung defect. Again, we can see normal or reduced FEV1 and a reduced FVC. And we should see a normal to even an increased FEV1 to FVC ratio. The flow volume loop depicted here shows a reduced volume. Often we say that these flow volume loops appear tall and pointy. The FVC is 67% of what we'd expect based on a normative value, and the FEV1 is 66% of predicted, and both are symmetrically reduced. So we see that the FEV1 to FVC ratio is actually 0.8. Again, spirometry is very helpful at identifying an obstructive lung defect, but it can be less helpful in clearly identifying a restrictive lung defect. In that case, we often use lung volume measurements. Lung volume measurements are helpful when the spirometry is suggestive of a restrictive defect, such as in interstitial lung disease. Body plasmography is one of the methods used to measure lung volumes. In obstructive lung disease, the FEV1 to FVC ratio may be reduced, while the total lung capacity can be normal to increased. However, in a restrictive lung disease, the FEV1 to FVC ratio may be normal to increased, but we should see that the total lung capacity, as measured by body plasmography, should be reduced and less than 80% of predicted. Lung volumes can also be helpful to identify hyperinflation in COPD or other obstructive lung disease. In that case, we can see an elevated TLC, an elevated TGV or FRC, as well as an elevated residual volume. In general, we identify hyperinflation when two of those three lung volumes are increased. For example, if we have an elevated TLC in an RV, we would identify those lung volumes as hyperinflated. Let's put all of this together and think about our flow volume loops taken together with our total lung capacity. Let's first look at our obstructive lung defect. Again, this patient may have a normal to reduced FEV1 and FVC, but they should have a reduced FEV1 to FVC ratio, and they should have a normal to increased total lung capacity. Let's take a look at this flow volume loop. Here we can see that our FVC is reduced at 66% predicted of the normal value, but our FEV1 is reduced proportionally more and is 38% of the predicted value. Thus, the FEV1 to FVC ratio is 0.46, or clearly obstructed. In this case, the TLC is 101% predicted, and so we identify this patient as having an obstructive lung defect. Interestingly, if we were to look at this spirometry and flow volume loop, we might question why the FVC is reduced at 66% predicted. This is when we can go back to looking at our lung volumes and capacities to help explain why that might be. I'm going to come back to that after we talk about each of these different lung volumes and flow volume loops. Let's look at the restrictive defect. Again, this should have a normal to reduced FEV1 and a reduced FVC, but we should have a normal increased FEV1 to FVC ratio, but a reduced TLC. Again, this flow volume loop is kind of narrow and pointy. In this patient, the FVC is also reduced at 67% predicted. The FEV1 is 66% predicted, but our ratio is normal at 0.8. We can identify our total lung capacity at 62% predicted. Sometimes patients can have both obstructive lung disease and restrictive lung disease. We can see this in diseases like hypersensitivity pneumonitis, where there can be both interstitial changes as well as airway changes. In this instance, we can have a reduced FEV1 to FVC ratio and a reduced total lung capacity. In this patient, our FVC is 78% predicted, and our FEV1 is 64% predicted, but the ratio is reduced with an FEV1 to FVC at 0.64. Now we can look to our total lung capacity and identify that the total lung capacity is 72% predicted or reduced. So this flow volume loop has features of both restriction and obstruction, and therefore we call it mixed. If we look at the flow volume loop, it has features of both. It's both coved and pointy. Now, interesting when we look at this slide, if we look at the FVC across the board, we can see that it's reduced in all cases. The FVC is 66% predicted in our obstructive defect. It is 67% predicted in the restrictive defect and also reduced in the mixed defect. We can say, why can that be? And this is where we're going to go back and look at our lung volumes and lung capacities. So this table can be really helpful for us to understand how lung volumes change and lung capacities change relative to other volumes and capacities as we measure them in spirometry. So here we can see that we have our total lung capacity. And again, if we look at our forced vital capacity, or here, VC, our total lung capacity is made up of the FVC plus the residual volume here. So one can imagine the FVC can be lower. If we squish down the total lung capacity, each thing should proportionally shrink. We should see a reduction in the FVC and a reduction in the residual volume. However, in some cases, such as obstructive lung disease, we may see, especially in hyperinflation, that our residual volume increases, even though our total lung capacity may stay the same or may even decrease. But because our total lung capacity is made up of only our forced vital capacity plus our residual capacity, as the residual volume increases, our FVC or vital capacity must proportionally shrink because the two together make up the total lung capacity. So sometimes in obstructive lung disease, we can see a reduction in the vital capacity, and that's because in many cases, patients have an elevation in their residual volume, even if their total lung capacity is not changed. Now let's talk about the DLCO test. The DLCO test is used to assess the gas diffusion from air in the lung to red blood cells circulating in the alveolar capillaries. The most common way to assess this is using a single breath or single breath hold of carbon monoxide. This test takes into account several different factors. We need to have circulating red blood cells, so if a patient is anemic, this can impact the value that we see. Altitude can also impact this value. So when we do this test, say in Denver, we have to correct for altitude as compared to this test being done at sea level. This test can also be impacted by fibrosis or inflammation in the interstitial space, because we can see that here depicted in this picture, if we fill up that interstitial space with either inflammation or scarring, it would be more difficult for oxygen to diffuse from the alveolar space into the red blood cell in the capillary bed. Also, in diseases like COPD, we can lose diffusion surface area by destruction of the alveolar capillary bed. And so in those instances as well, we can see a reduction in the DLCO. Outlined here is a nice algorithm that we can use to help us work through the data we find in both our spirometry and lung volumes. Let's walk through this table and look at the different ways we can get to a diagnosis. So first, we would assess the FEV1 to FVC ratio. If this is low, like we've talked about in obstructive lung disease, we would then assess the FVC. If this is normal to high, we could identify an obstructive lung defect. Then we can move on to assess the DLCO. It may be reduced sometimes as in emphysema, or it may be normal as in asthma or chronic bronchitis. Now, if we look at the same set of data again, but take a different path, we first assess the FEV1 to FVC, and we identify it as low. And then we move on to assess the FVC, and we identify that as low as well. Now we're wondering, what is going on here? So we can look at the total lung capacity. So if the total lung capacity is also low, we have identified both an obstructive and a restrictive defect, and that puts us in the mixed category. However, if the TLC is normal or high, then this likely identifies an obstructive lung defect. Remember, we can have a low FVC in the context of an obstructive lung disease, especially if the residual volume is high, because the total lung capacity is made up of the FVC plus the residual volume. And if the residual volume becomes elevated, the FVC is proportionally decreased. Now let's take a minute to look at the other side of this pathway. If we assess the FEV1 to FVC and we identify it as normal to high, we then move on to assessing the FVC. If this is again normal to elevated, we identify normal lung. We can then move on to assess the DLCO. And if that is normal, then we say that these appear to be normal pulmonary function testing. However, in some cases, we may have a normal FVC and normal lung volume, but a low DLCO. In that case, we become worried about pulmonary vascular disease. If we again look at this pathway and the FEV1 to FVC is normal to high, and then we assess the FVC and identify it as low, we then need to move on to the total lung capacity. If this is again low, we have identified restrictive lung disease. If the DLCO is low as well, this is likely interstitial lung disease. However, if the DLCO is in the normal range, we should think about chest wall abnormalities or neuromuscular diseases. This is a good time to point out that restrictive lung defects are not only caused by parenchymal lung disease, such as interstitial lung disease. We can see changes in the pleural surface or the chest wall causing restrictive lung defects. Imagine the case where you have pleural scarring. Our pulmonary physiology in that case may show a reduced FVC and a reduced TLC, but in general, the DLCO should be relatively normal given that the lung parenchyma itself is normal. Let's move on to our illustrative cases. I think this will help put all of this information together. Let's start by going through the data. Here, we can see that the FVC is reduced compared to the lower limit of normal at 3.96. The FEV1 is also reduced compared to the lower limit of normal, and the FEV1 to FVC is normal compared to the lower limit of normal. So let's start on our pathway. We're going to assess the FEV1 to FVC ratio. And we see here that the FEV1 to FVC ratio is 0.79, which is above the lower limit of normal. So we would say that this falls into the normal or high FEV1 to FVC ratio. And we're going to move on to assess the FVC. So let's go back to our data. In this instance, the FVC is reduced at 2.89 compared to the lower limit of normal at 3.96. So we say there is a low FVC. So then we move on to look at the lung volumes. Let's assess the total lung capacity. If we look at the total lung capacity, it is again reduced. It's 4.22 relative to the lower limit of normal, which is 5.91. So this is considered low, and we have identified a restrictive lung defect. Then let's go on to look at the DLCO. Here we can see the DLCO is 12.65 relative to the lower limit of normal at 21.82. So this is a low DLCO. So this likely represents pulmonary physiology that we might identify in someone with interstitial lung disease. Because again, we see that the FEV1 to FVC ratio is normal. There is a low FVC, a low TLC, and a low DLCO. In case 2, let's look at the flow volume loop. We remember this flow volume loop. This is one that seems short and squished and maybe a little coved. So let's go look at the primary data and see what we think. First, let's look at the FEV1 to FVC ratio. Here we can see that the FEV1 to FVC ratio is 0.47. This is less than the lower limit of normal at 0.63. So this is a low FEV1 to FVC ratio. We then move on to look at the FVC. The FVC is 2.18 relative to 2.28, so again, reduced. Then we can look at the total lung capacity. Here, the total lung capacity is 4.92 relative to the lower limit of normal, which is 3.85. So it's normal. So we would identify this as having an obstructive lung defect. That confirms our suspicion that we initially had when we looked at the flow volume loop. We then move on to assess the DLCO. And here our DLCO is 14.1, which is less than the lower limit of normal at 15.75. So here we can be suspicious about emphysema. We can get even more data from these lung volumes. Let's go back and look at the residual volume. Here, the residual volume is 2.77, which is above the lower limit of normal, and 131% predicted. Taken together with a normal TLC and an elevated TGV at 146% predicted, we can call this hyperinflation. Now, going back to thinking about our lung volumes and capacities, we can here identify that this FVC is actually only 79% predicted, which is actually mildly reduced. That might be expected in this case because we know that the residual volume is elevated, and the total lung capacity is made up of the FVC plus the residual volume. So taken together, this case identifies someone with obstructive lung disease and hyperinflation with a low DLCO, and this is often seen in our patients with COPD and emphysema. Thank you for joining us today. I hope this presentation helps you better understand pulmonary physiology and helps you interpret your patient's PFTs so that you can help them with their underlying lung disease. Outlined here are a few amazing resources that you can use to better understand interstitial lung disease. Again, thank you for your time.